of balloons and catheters. The first balloon is initially was made by Schneider company. So this is the lesion which is there in the proximal LED, and then once the angioplasty was done, with the plain balloon, the lesion opened up like this, and it was again rechecked later in 2000, and it is still working all right. So that's how the history was created. And then later on, again he checked. Then this conducted a lot of these courses in 80s. And just to take you through my memories also, this is one of the 1995, one of the first angioplasties, but play POBA, which we done in HGPGI. But the thing was, when the balloons were done, then the vessels were getting closed. So a lot of times we were forced to sit with the patients as residents also. If something happens, we have to immediately address. In those days, perfusion balloons were also used, and then what to do, we were thinking, we have to avoid this acute closure. That's how the stents have come. So to prevent acute closure, first it was studied, but later on, again, it was also shown to decrease the restenosis. How it evolved, I will just to take you through. This is a preliminary model, and the later real stents implantation started with Palmer-Schatz stent. This is the first human implantation of Palmer-Schatz was done on December 31st, 1987. So exactly a decade, probably. 77 was angioplasty, 87 is stent. Giulio Palmer is the one who was instrumental in developing this. Patrick Serrais with Benny stent study, which showed minimal lumen areas gained were very high compared to balloon angioplasty. And then stress restenosis, again, Martilian was the investigator for this, and they showed that probably by using this, not only the immediate results, areas improve, but on the follow-up also, patients did well. And revascularations, repeat revasculations in the stent group was much less. That's how they became wiser. The stents also decreased the repeat revasculations and decreased the incidence of restenosis, which is about 30-40% in POBA, which decreased to about 15-20% with bare metal stents. So initially, we used to do with resistant patients of maximal medical therapy, single vessel disease, proximal stenosis, because these lesions were very tough. This is to just to recapitulate one of the first patients which we did immediately after we passed out in the career. This is left circumflex artery. This was a patient who works in one of the film theaters. We still remember. He's still doing all right. Then we did dilatations, and after that we put a stent. That's the markers in between the stent. I think then the totally perfect result, you won't even make out the restenosis lesion where it was. But again, with the bare metal stents, we still had restenosis rates up to 20 to 50%. Then this was atherosclerosis, which is happening. Initially, brachytherapies were tried. Colombo et al. Said that probably high pressure inflations with IVAS guidance would decrease the restenosis. That also helped, and that era, antiplatelet drugs also came. The acute thrombosis decreased, and the stents were started behaving better. So we also had better technologies to image the plaques inside with IVAS. And then the revolutionary discovery of Cordis Johnson & Johnson's company came, which is sirolimus drug called Cypher stent. Cypher, in fact, they labeled it to say it as a zero. Cypher means zero restenosis, so no restenosis at all. Initially, the first set of patients, type A lesions, which were done, they claimed that there's no restenosis with Cypher. They thought they conquered the restenosis totally. December 1999. 97 was the first stent. 99 was the death with Cypher, which came. And when they had 2-3 types of drugs before, one company came with paclitaxel, other with Limus, and then both stents were going all right. This was Taxus, and this was Cypher. Going all right. Then Renu Virmani and others, many of them mentioned these drug-eluting stents. They have a good things of decreasing restenosis. They were bad and ugly because they delayed healing. They caused a lot of inflammation, and sometimes stent thrombosis was happening, and also abnormal vasomotion. So research went on how to avoid this, and a lot of different drug-eluting stent platforms came, and some are stainless steel, some are cobalt chromium. Then the Indian companies also started doing it, and one of the first ones was Care Polymed. There's all coiled stents before, then later they became started tube stents. I would take you through the stent anatomy in a short while. Then we thought which stents are good, whether Limus group or paclitaxel group. Then comparison studies were done. and showed that probably sirolimus drugs, everolimus eliciting stents were better than paclitaxel. That's how the paclitaxel stents became less and less popular, and the limus group is being studied more and more. So if you now see the better quality of stents, now you have all the types of multivessel disease, left main disease, calcific lesions, eccentric stenosis, all being treated, and total occlusions, bypass grafts, you name anything. And they started, we are managing them, bifurcations, restenotic lesions, all that. So this is the first generation stents, which are became very trackable, and then Staxis and Cypher. Then, but the problems of them were noticed because of polymer. So then research went on, and we went on to more benign and more patient-friendly, more human-friendly polymers, which is fluorocarbonates, which is actually when initially Endeavor platform had BioLink, and then Promus Element and Zymes had hydroxy fluoropolymer, which was more friendly. Actually, if you put a blood on it, albumin gets deposited on it, and the antiplatelet effect is also seen with those polymers. That's how I think gradually more and more interest on the things came. And 1 minute. So then, Limus group of drugs were becoming popular, and everybody was trying to develop various derivatives of Limus group of drugs. Coming to the various things, people were started surprisingly getting into so many types of stents available. And what is the choice of stent? That is, so many drugs are available. You take select because of the experience of the doctor treating. Similarly, you need a lot of drug thickness. If you see the predominantly what are the important things of a stent is basically stent has to be deliverable and it has to give an immediate good result, and then longer for immediately it has to be safe to the patients without SAT, and then follow-up results should be good without increasing TLRs and restenosis rates and follow-up. If you have to see how this is happening, the four important components of any stent would be basically stent scaffold, which could be metal, which is a stainless steel or cobalt chromium. Later again could be vascular scaffolds, it could be absorbable material. Then because the drugs cannot be directly deposited on it, initially the polymers were used. Then later on, the polymer-free ones are also being tried by making porous surfaces on the stents. So that is the drug, and the coating technology is a polymer. The stent delivery system is also important, how to track the stent and all this. So these are the important components of tests. So advancements went on to happen to improve the research in all the four fronts. Then stents, so initially, which I said were just long wires, mesh. Then it was started cutting tubular structures. One from one tube, it is being cut into the various designs. Then that's how they became having more radial strength. So later modifications also happened. Wire configurations were also seen, and then this is various companies had different types of designs. So basically, if you see, this is called as peak. This is called as trough, and the attachment is from the peak to trough here. This is peak to valley. This is Zion's platform, and then in between both is Orsero platform. Each of them have some advantages and disadvantages. Onyx has again called wire meshwork technology. Advantages of it I will take you through. Metal to artery ratio, though you have the suppose less of to avoid less of plaque prolapse, you want more approximate covering up with this metal struts, but at the same time, metal to artery ratio needs to be balanced. If it is too much, then again, probably restenosis could be high. Somewhere 13 to 15%, 18% ratios is what is acceptable now. At the same time, stent should be also, the scaffolding should be good, and they should not produce any breakages or damages. It has to be adhering to the arterial anatomy with complexities and the tortuosity of the arteries. Then when they were making the struts thin, you should also have the radial strength to keep the stent opposed well to the walls. And you have the existing things which are available, radial strengths of the various stent struts, which are mentioned here. And then geometry of the stents, connection of the stents matters in maintaining the strength of the longitudinal strength of the patient. If there is stent, suppose if it is too thin, and then probably if you push it with guide catheters, and they could get collapsed. That's what was happening in the earlier version of Chromus stents, which were later modified. So that's how the longitudinal shortening, if the studs are too thin without proper anatomy, then probably the longitudinal shortening could happen, and we could miss the lesion, or patients could have trouble on follow. So again, once you have deployed it, it should remain same in the same way it is deployed without further shortening later. Other important character of the stent is this struts in between these stent designs. What do you call is many of the people would get confused between the open cell and closed cell designs. So basically, if you have this entire thing open like this, it is called open cell design. But each of the struts, suppose if it is united like this, then probably it could be closed design. Many of the stents have now a combination of open and closed cell, because we know that closed cells are required to maintain the strength, and open cells are required for the side branch axis. And depending upon the type of area which is available, which is written here, probably most of the latest versions of the stents have 1 mm around axis, so that it would be easy to take the newer balloons through the stent struts if you have to open the dilate these struts for a branch axis. And generally, the stents which have maximum open cell design quality is preferred. Then crimped and expanded images, again, what it is trying to show is once it is crimped versus expanded, the stent should not get shortened, and the markers and this should be same. So by and large, most of these things achieve that because of improvement of technology. Dealing with most of the US FDA approved stents, not much discussing with the Indian type of stents, touching upon some of the newer version of the stents which came in India, which we'll deal later. But most of this discussion is around the US FDA approved stents. So stent material is another thing. Balloon expandable stents, you have stainless steel, platinum, chromium, cobalt, chromium. All this is because it has to be having higher radial strength, radio opacity, thinner struts possibilities, and then probably biocompatible is important. So as we now know that strut thickness is important, the more thinner the struts, the more better it is for the patient. The first generation stents, which had a very thick strut, Cypher had 140 microns thickness. And then gradually we try to decrease the strut thickness. The latest second generation, third generation ones are very thin. Now as low as 60 microns is Orsiro stent. I think it is mentioned here, 61 microns is the lowest profile stents which are available. And that's how the stents become better trackable. And coating of the stents also depends upon the type of drug which you're using. So these are the polymer coating is what, again, as I mentioned, is important. So in the stent material over which you have the coating all around top coat design. And then depending upon the drug which is there and the polymer type which is there, which you need not remember all that, but basically most of the materials are now fluorinated polymers, and which are very patient friendly, human body friendly. And the beauty of these polymers now, unlike the Cypher and Taxus, which had toxic polymers, is these are supposed to be thrombo resistant. The albumin gets deposited on those polymers, and it doesn't allow the platelets to stick on to that polymer, which is actually, that's how I think some of the studies which came, the drug-coated latest version of drug-coated stents fared better than the bare metal stents, surprisingly. On follow-up, some of the reasons when they were trying to see, that was probably the reason by which these drug-eluting stents became thromboresistant. If you see the various commonly used stents which are available in the market, I've mentioned here, most of the things are limus-based drugs. If you see, there's no paclitaxel. Zymes has everolimus. Resolute platform is otolimus. Synergy again has everolimus. Ultimaster is sirolimus, Orsiro sirolimus, and Biolimus stents had Biolimus. And the drug elution patterns is also, if you see, it varies from 90 to 120 days, maximum of 180 days, because that is the period in which the maximum restenosis happens. So if the drug stays till that period, then probably chances of getting into trouble would be least. Then which phase of the cyclic replication of the drug is acting? If you see, most of the libus drugs act in the G0 phase. This is the cytostatic phase. And that's how the new atherosclerosis, new cell formation within the stents is prevented. Now let us see briefly about some of this evidences with these stents available and the various indications. Zines, I think, by far is the like the cipher of Esther era. We have a large number of patients, large studies done compared to all others. They started with Spirit 1, 2, 3, 4. I really appreciate Abbott for getting these multi-center trials to our country. And many of our physicians and centers in our country were also made part of it. And they did do one specific subgroup of patients, Zines V in India, with about 1,000 plus patients in 2010. And Spirit Woman was another study in which we again specifically it was studied for women patients. And then later they had also Excel study which came in left main subsets of patients, showing all that this stent works very well. And now we are moving more towards a short adapt and single antiplatelet drug things. And then expert C2, all that was tested in the Zymes platform. So any new stent comes now, they keep testing with the Zymes stent. This is Spirit Woman study. We have fond remembrance of this. And then Mary Claude Morris was the principal investigator. We were the leading recruiters in the 2007. And probably 67 patients were recruited. All patients did well. That's how it became the stent of choice in women in those days. Stent thrombosis rates were very less. And then that's how, as it goes on and on, also the thrombosis rates are much, much less, 1 to 1.1%. And we have the longest follow-up data up to 10 years in this platform. And about 15 lakh plus in implantations run in our country. Overall, the world, I think they have the leading market as of now. Then 15 million implants, that's what the company claims. And stent choice in most of the situations probably Zymes. But you have to also know where to prefer other platforms like Resolute Onyx and Orsiro, things like that, which we'll be dealing. If you see, to just precisely mention to you one or two case examples, if you see, this is, I think, a tight ostial left main disease, which is best profiled in cranial view. I did show this before. And such sort of things where precise placement is required. The Zymes platform has an advantage that the marker and the stent start together. So the position, again, cranial, I need not go into details, but you can precisely position without missing the ostium. And then probably that sort of things where you need accurate placement and limited only to the left main, probably you could use those. Similarly, it could be also LED ostial placement, L6 ostial placements without going on to impeaching it. So you could take the advantage of this platform and use it. But it's very important for us to use the right stent and do it immediately faster. Otherwise, sometimes the left main inflations could lead to bradycardias and hypotension. Patient could develop trouble. Other important thing once you're doing an ostial stenting is what we also do a part and then probably inflate further ostial flaring once you get it out, and then probably we also image it. It is not a point of discussion today, which is dealt in the last class. But what is important is precise placing of the stent. If it is required, probably this platform scores over it, and it has the radial strength to keep it, maintain it well. That's how the results come well, and the patient did follow doing all right. So that's about the precise placement. See this. This is another 40-year-old male, chronic smoker, unstable angina. You are not able to see what is happening here. You have diffuse ectatic vessel, long segment disease, bifurcation, RCA, huge RCA, bifurcation disease, PDA disease, and PLV distal disease. And same thing is seen here. Obviously, 40-year-old, we don't want to send the patient for surgery. So we decided to proceed, explain repeat TLRs could happen, and started doing the procedure. As you see, we wired both lesions, started dilating. Then initially, the distal-most lesion, we need to tackle it first because it sometimes unless the proximal lesion is very critical, generally we tend to tackle the distal lesions. And then we have used distal stent here. Then we went on to go on to tackle the PDA lesions. For the sake of time, I can't go into all the details, but then sometimes you need to take the help of body wire to track the stents also. Then the proximal portion of the RCA was also stented, and the entire artery was reconstructed. So in this, you see this pre-image where you have ectasia narrowing here, narrowing at the junction, narrowing distally, narrowing. And this had a very type 1 LED, which was occluded long time back with a patient and had no RWMA, nothing. So this is huge RCA, which was behaving like LED was tackled. and the entire artery could be reconstructed with a better quality of stents which are available. Such sort of long lesions where there is high chance of restenosis in younger patients, probably we bank up on this platform to have the better results. But you should so that's how we are able to be confidently deal with this subgroup of patients and give good results, and patients doing all right on the follow-up. I think before going to other platform, I finished talking about Everlumus, this Zines platform, and probably we could have some discussion Kahoot, or we play basic Kahoot quiz. Any chat questions?
I think there is a chat question is there, sir.
Dr. Ravindra Reddy, to everyone, sir, what is the status of bioabsorbable stent and evidence and new generation? I think if you give some time, Ravindra, and I'm very happy that he joined, we will discuss in that in the coming. I'll end with BVS and then we'll have more discussion on that, if it is okay. I'm talking about the newer drug-eluting by BVS stent which will come to market. I will show you the data in the end of the talk. Give me a few minutes to change onto that, and then probably we'll play this basic Kahoot quiz. And meanwhile, I want you to more people to put me the chat questions regarding whatever you spoke. Any chat questions, more questions, any doubts in regarding what all we discussed? You're able to see the new screen of iPad?
Yes, sir. We are able to see that, sir.
I think for people who have seeing the screen, you can join this challenge if you type this number there, 06032428. Is something wrong? Are people joining?
No, sir.
I don't see people. Maybe
Yeah, we are just checking, sir.
some issue in this thing, or is it okay? Can take 2-3 minutes time.
Yeah, 1 minute, sir. Yeah, they joined in, sir. We can wait for a few minutes, sir, so we can have more participants, sir.
Yes, we'll wait.
Yes, sir. So,
Anyway, I think some of them need help. It is coming. I don't know how to take it. Each time this is.
Can you play it, sir?
Yeah, I'm just trying to do that. Actually, this is the earlier version played thing showing. I think they can join with this. That was a old one. Sorry, 0476 5335. That's why many could not join because it was an earlier version which had some limitation. 0476 5335. Zero four seven. Bottom line you get 0476 335. When you open your Kahoot quiz, below it, you enter your pin, it comes. Once you enter, then you will be able to join. There's some problem, I think, this time. Only one person could join. Yeah, I think there are more joining. 4 are there.
Since we have changed it, now they will be logging in through this, sir.
Okay. I'll put the share pin again.
No, it's fine, sir. We are keying in, sir. Already there are 4 are there.
0476 5335.
Yes, sir.
Anyway, I think they'll participate in the advanced one also. And some of them, the basic ones are, I made it just to.
Yes, sir. You can then start the game, sir.
I have now 11 players who have logged in. And 12. The first stent type to be used in 1988. I put a figure to point it also. First stent which was used: Cypher, Zines, Pharma Shots, and Meris. Cypher was regulating stent. Zines is the most advanced present stent which is commonly used. Yeah, I think people have answered it. Some of them right, and some of them may be taking more time. Then NK has answered right. If you answer it faster, also you get more points. Then probably as we go, the type of questions also will increase. What does cipher mean? Cipher means moon, number 10, 0, or sun. So why was the term cipher given to cipher stent, indicating what? We know that cipher has revolutionized the regulating stent. As I mentioned, the answer here is basically cipher means 0. 0 restenosis. To highlight that aspect, they have kept it as cipher stent. I think NK is leading now. Then we go on to next. Which most important drugs which decrease the MACE and SAT are what? So type of drugs: antithrombotics, antiplatelets, silastazole, or statins. So obviously, when I mentioned here the above article of Antonio Colombo, where the ticlopidine was the drug which was used before, and then later we have a lot of modifications. And then antiplatelet drugs is the ones which have decreased stent thrombosis rates, and then probably changed the way we treat these patients. The figure is there above. I wanted everybody to know this, and if you can type the answer, then you'll get full points. Who is the person besides that main person in the apron is also you could score you additional marks. Father of angioplasty, I did mention, open the talk with it. Many of you would know it, but just to encourage more people answering, I've kept it. Yeah, many of you would have answered. I think Andrea has grown sick. The answer. The next besides him was the patient. The most commonly used drug in drug-eluting stent platforms now is what? Paclitaxel, heparin-based, robucol, or limus derivatives. So basically, the basics would be touched with basics of stent with some interesting history points. That's how I kept it. I think you know limus group of drugs now, everolimus, sotolimus, are the ones which are being tested. Paclitaxel is given up. Propicol is another thing which is thought to be better. Combinations were tried, again, not useful. Heparin-coated stents were also tried before. Initially, they were supposed to be better than the native bimetal stents, but later given up because, again, they didn't work. So everything is, the research is going on the limus derivatives. I think with this, we finished our 5 questions, I think. Then this is going to practice. I didn't answer here. That's why on my thing it is showing. That's okay. So I think we finished this. The answer, though, the final thing would be again mentioned in the end of it. That is the end of a basic quiz. Now I'll stop sharing and also go on to proceed to the more interesting aspects of our talk, where which type of stents which we select depending upon what lesions, what patient anatomies, and some more details about other new platforms of stents available, which we'll discuss. Then, in the same time, when the science platforms were going on, Resolute Medtronic was also doing active work. And the Resolute drug-eluting stents were again being tested with science platforms, and both of them did perform well, even in the complex scenarios. Resolute multi-center trials were done, the US, Japan, Asia, China, India, and had a long-term good results on this platform. Resolute Asia, including the large stents of 38 dual vessel cohort, we are part of this, and then significant number of patients were recruited, and this stent also proved that it will be useful. Then the research went on. They modified the stent, design of the stent to Onyx platform, that is to make it more and more deliverable, and stent sizes also decreased. Even from 2 it was made available, and that's how this went on to treat small vessels also. Small vessels, they said 2 2.25 mm. Then the advantage, the beauty of this platform is supposed to be like apart from the cobalt alloy metal, initial they have platinum iridium core material inside. That's how they became more radio opaque. And then probably the same polymer was used, the Bilinks polymer, which was more user friendly. Then, but the design was all this wire pattern were again united, and every fourth chrome was fused, every fifth chrome is fused. Basically, not going into all the details, but it's basically fusion pattern of this wire material with outer core and inside iridium. That's how the radial strength was maintained and the strut thickness became thin. And one important thing which we need to know with the various types of stents is the expansion limits of the stents. Nowadays, we put stents in the bifurcation. The proximal vessels are bigger, distal vessel is smaller. We take the size of the distal vessel and expand it to the proximal vessel. That's how we do it, but each stent has its limitations. So if you take a 2.25 stent, the maximum it can go is up to 3. In the Synergy platform, Expedition, it can go a little more. Onyx, it can go up to 3.5. So we need to know about each of this. This is actually need not mug up. This chart you can put in your labs. So that's how if you have to go to left main, then probably you always need to take 3.5 plus stent so as to have expansion up to 5 plus. Then extra large vessel stents, some of them are launched. Resolute Onyx launched before, and Expedition has Sierra, and Synergy also has some newer models which are not available. So whenever you want the stent size to become bigger, around 5 or so, then that's how the Resolute Onyx out of the available ones are being used more commonly. Then this is at various atmospheres of pressure. Nominal pressure is where the stent, about 2 mm stent becomes 2, that is a nominal pressure. But if you increase the pressure, then it will go on to higher diameters. That's what this shows. But again, you should not cross that expansion limits. So 2 should not cross 3.25, 2.25 should not cross 3.25. Basically, below 2.5, you have one tube, and above one, you have another tubes by which the stents are cut. So if you have to have a bigger size stents, then probably 3 plus would go up to 4.5. That is a broad way to remember. But depending upon the anatomy and patient lesions, we select it. And that's how the stents, even the 2.25 stents are made available. First in the Onyx platform, then later on, it also came in the Zines platform. And various Indian companies also do have that. Such sort of critical lesions when you're doing, and when there's no osteal LCX disease, then probably you tend to do a crossover stenting. I'm not going to details of imaging, which we discussed last time, but suffice to say that if you place a stent across from the, if you're taking stent from the left main to LAD, because LCX is free, you dilate the stent, you see, you size the stent to the distal vessel, then probably the proximal vessel will be bigger. That's where you call it as proximal optimization of the stent. So that's the result which you got. But at the same time, you have to make it opposed in the left main. That's why the proximal optimization with a bigger size balloon is done. But when you're in the process of doing it, in the earlier version of the stents, when you are expanding proximally, they used to become narrow distally. But the changed anatomies, now even if you expand there, it remains expanded there, and again below, the stent anatomy does not get distorted if you are within that expansion limits what I mentioned. So that's why it's very important to see, and so that the distal anatomy of the stent here should not get crimped again when you're inflating proximally. This sort of things are possible with the latest version of stents. I'm not going to detail. Such sort of good outcomes are possible with the present generation of stents which are available. See this again. This is again 80-year-old. Our patients also started simulating West. These are patients who is admitted with recurrent rest angina, probably admitted with ischemic LV of recently. And see this type of tortuous vessels. In the earlier version, earlier generation ciphers, you never could track such lesions. See this, identify it well. And when you're dealing with such tortuosities, another problem is the concertina effect happens when you are placing the wire and everything gets into very focused narrowings. So you need to identify yourself the proximal point and the distal point where you have to place the stent right, so that the branches could mark as the landmarks for you, even if the anatomy gets into kink with the concertina effects. So that's how you should try to identify these marks. And always, when in doubt, get back the stent, image with the contrast again, place it while contrast is being injected. Right one was all right in this lady. So this patient, we had to see this tortuosity of the vessels, so many. Then we initially took one wire, and luckily the wire went in easily. Then we thought we could do it. But as I said, the arteries started becoming more and more kinked. There is a small ectasia there, and then its stent was getting stuck there with one wire. So we dilated it, thought there is a tight lesion there. We dilated it, but still, stent was not tracking, again getting stuck there. Then the additional wire, like a buddy wire technique, was used again. That I call it stirrup technique. Generally, if two wires are tucked together, it becomes very tough there and straightens all the loops. That's how we could place the stent right. And whenever you cross the lesion, stent should slide down distally easily. If you're not started pushing and it's not going, that means you're still proximal to the lesion or within the lesion. So you'll end up missing the lesion. Always when you cross the lesion, try to push the stent down and see whether it is tracking down easily or not. Then only that means you have crossed the lesion well. So then you do that, and then you position it well, seen the branch, and then that's how we could do the stent. And then the proximal one, once it's done, the distal one, once it is done, the proximal one are also easy. And such sort of tortuous anatomy is generally in the calcific lesions where you find it more challenging. Probably we prefer Onyx type of platforms, which are slightly more trackable. See this, the entire artery lesion here was treated, lesion here is treated, and then finally patient did well, and we could discharge this patient without much of problem. Some of the newer data which are dealing with 80-year-old patients, like high bleeding risk, what we call. So, giving dual antiplatelet therapy is a problem now. So, people started thinking whether we can decrease the duration of antiplatelet therapy or do away with dual antiplatelet and giving only one antiplatelet drugs. That's how the Onyx was tested. Onyx One Clear study was done in US and Japan, saying that instead of giving two drugs, giving one drug could be beneficial. It's important for us to realize these patient characteristics of high bleeding risk, age more than 75, and oral anticoagulation, renal failure, planned surgery. Patient has in some TKR patients need knee transplants or things like that. Also, we see anemic patients hospitalized for history of bleeding, thrombocytopenia, cancer being treated nowadays. We also see such patients, strokes, chronic liver disease, NSAID use, or adapt non-compliant. Such are these patients of high bleeding risk. If you're dealing with such, then probably you should put a stent which has data with more shorter antiplatelet drug therapy. That is like resolute Onyx. Then later on, Zymes came with Zymes 1 that saying that 1 month adapt and things like that. So if you see this in Onyx 1 Clear, within 1 month, dual antiplatelets were stopped and most of the patients were put on single antiplatelet drug, which was continued. Mind you, we are not comfortable putting single antiplatelet drug because patients initially were having an aspirin and clopidogrel here. Their outcomes were much better, even if the single antiplatelet drugs also, the thrombosis was not much increased, but bleeding was decreased. And that's how they showed that this trend works well and clearly met the primary endpoint, what we thought after DAP discontinuation also. These high risk bleeding risk patients behaved all right. That's how now we are becoming more and more confident of dealing with HBR patients and patients due for TKR, things like that also with 1 month antiplatelet therapy followed by single antiplatelet drug later. I will show you some examples of one of the tortuous vessel I've already shown, the small vessel PCIs. Nowadays, vessel could be size-wise, diameter-wise, it could be small, but it could be long, supplying a lot of areas. It's especially seen in diabetic patients, and probably 65% of these small vessels which are not treated. Distally, you leave it, but proximal and mid segments, you tend to treat it. And tortuosities, tapered vessels, all these were dealing with the problem. Now, with the availability of better quality stents and then this sort of using this sinusoid technology, core wire technology, and radio opacity is also better. Nowadays, you find extra small vessels versus small vessels when they compared. Actually, they did well. Thin struts also matters, I think, to decrease the restenosis rates and keep the areas more. And both extra small vessel also behaved well, and especially even in diabetic subsets in this resolute onyx subgroup, they did all right. So 2 clinical study was extended even in US. That's how the recommendations came that you could treat even 2 vessels provided it is important area of supply. So then they did all right, reached the performance goal, and the TLF, TLRs and follow-up and especially thrombosis rates were not much different, and late lumen loss was also not there. If you see some of the case examples which we faced, a very thin vessels, 68-year-old female. For sake of time, I won't go into details of all the clinical stories of the patient, but show you the pictures because seeing the angiogram itself, you'll be able to tell. See that there is a tight lesion here, the tight lesion here. We wired it. Some of the challenges, again, you could take the help of buddy wire, then take two distally very thin, 2 into 30 stent was taken, then proximally again 2.75 to 30. Entire artery is reconstructed. And the beauty of this is distally, if the vessel is small, it can be thin. The proximally, there are more compliant balloons inside, and you will expand better. You can expand the proximal portions with bigger size balloons also. That is the advantage of later generation stents. This is another 74-year-old lady, and initially stent was done proximally, then it developed in LAD, now it had developed a new disease in LCX. Again, thin stents were put, and then patient had good outcomes on the follow-up. Then when the left main was also diseased, then probably you tackled that and dilated, then the patient had finally good outcome. That's the things what is shown. This is another patient presented with unstable angina. See this, only OM. Normally we would leave it if it is thinner without availability of this type of stents. But this area supply is quite big, we thought. Then it is tackled, and then patient had good result. So this patient's angina decreased and then improved well. So another patient who came after LED stenting before, and distal to it, you have tight stenosis. Many of the times we leave it, but somehow this patient had ongoing angina, and he was requesting something to be done. So we were not sure whether we can tackle it effectively, because distally again it could dissect and lead into trouble. With the availability of this thinner studs, we did do it, but again the proximal to it did expand well. We had to take the help of NC balloons and dilate it again within the stent, and finally patient did fine. So already thinner stent studs, if you don't expand it well and residual narrowing, then they may tend to restenose more. That's why you need to get the optimal result. This is another thin vessel of RCA. RCA generally are deceptive. Again, you see it looks like very thin vessel, but a long vessel. Critical stenosis, then multiple stents being put. For the sake of time, not going details, but entire arteries are being reconstructed. And because of less restenosis, less TLRs and follow-up, we are able to give good results to these patients. This is another patient of, I think, anterior MI stent, had a total occlusion of LAD. We crossed with Fielder XT type of wires. Another usage of this thin stent, I'm trying to show it here. The proximally we did dilate, but distally, once the vessels were done, the flows were not established. But later on, we put another thin stent distally, and that's how the entire artery could be revascularized totally. So when we are trying to see, the stent studs became thin, and then probably we had a better polymers. Then people are trying to see eliminate the polymer altogether totally, and eliminate the stent scaffolding metals totally. That's where the research was going on. And if you see this Orsiro stent, which has 60 microns thickness, and compared with Zines, and one of the studies showed better. But when we went on to see target vessel failures, again with all the types of stents in this multicenter analysis by Greg Stone, the randomized controlled trial analysis, then TLFs were not much different. Even with regular compared to Zines, stent thrombosis was also not different. So that's how they said that Resolute Onyx and Orsiro were also compared, which had again similar results on the follow-up. Stent thrombosis, actually in this particular thing was less with Resolute Onyx, but even with this other one was not much high. So that's how, even making it further thinner, people thought it may not have additional advantage. So somewhere around 70-80 microns probably could be okay. And then various types of comparisons with bare metal stents, various types of other drugs is going on in this randomized trials. But it is difficult to further improve on this good outcomes, low TLRs already. That's how I think we are there at that point. Then platinum chromium, then they've made it further thinner, synergy stent, and absorbable polymer, what is there in it. They try to compare with a non-absorbable polymer versus absorbable polymer. It didn't show much of difference there. So polymer-free metallic stents probably had some advantage. That's how the biofreedom stent was tested. The microporous structure was done, and the bioluminescence drug was implanted on that direct metal with micropores. But again, when you are trying to see with the bare metal stents, they fared all right. Decreased event rates compared to bare metal stents. But when we compared with other drug-eluting stents, then again there was not much of difference. This sort-out trial compared the biofreedom with Orsiro. Again, it was not different. So when the polymer was there or not, it was not having much of a difference. On the other hand, when the bare metal stent showed some slightly more events than the biocompatible polymers, people thought they're protecting from the thrombosis happening. That's how I think more patient-friendly polymers are being preferred now. So when we are trying to see whether we can totally get away from the metal and not have metal at all, the bioabsorbable platforms is what is being tested, because especially in young patients and patients who need surgery before, later, and then where you don't want it to be having across the branches, all these PCIs in younger patients, probably you would want a bioabsorbable stents. Initially, Igaki Tamae came with a PLA-based thing, BVS, which was done from Abbott. It was already launched, hyped much, but it was used irresponsibly. All the colleagues without bed preparations, without post-dilatations. Strut thickness was also bigger. That's where I had some issues. Then further research is going on with Riva platforms. which is about to be launched, and Biotronic is working with a magnesium-based platform. This is absorbed BVS, fully absorbable, but the strut thickness was 150 microns here. The drug again was same with like a Science platform. Then balloon expandable, 150 microns was the problem. Radial, same multi-link design was used PLLA polymer. Initially, it did all right, but when the follow-up results then had more thrombosis rates and stents landed in trouble with 3 and 5 year results. That's how it was given up. The important concept, if you understand, if you see this, immediately after the stenting, if the restenosis happens, it is going inside. But if the stent starts get absorbed over a period of time, the luminal area could increase with a bioabsorbable platform. And Patrick Serres also said when it is getting absorbed, this endothelium inside could become more resistant, and it's like golden tubes, he called it. If you see this, stent starts, post-stenting immediately, 6 months gradually getting absorbed. At 24 months, if you see the OCT, the overall area increased, and this endothelium became more resistant, and that's how I think the vision was it works well on follow-up, patients doing all right. But because of improper bed preparations, a very thick stent struts had more thrombosis rates, and vasomotion was also supposed to be good with this BVS once the metal goes. But in real world, it didn't happen. That's how it was withdrawn. Then, if you other advantages of these absorbable stents, what it showed is some very well shown in this OCT studies. If the strut is across a branch like this, if it gets absorbed, then it becomes totally free like a normal vessel. So that's how the advantages were thought. Then overlapped stents were also being done. That's how I think when you overlap it further, the thickness increases because each of them were having thick struts. We are part of this absorb extent study, which was presented and published later. And then, because of the more problems on follow-up, then this was withdrawn from the market. Then when people went on to see what was the problem, how to improve this technique, probably bed preparation and definite imaging, and probably better quality dual antiplatelet therapies which are available like ticlopidine and prasugrel would help. And how to improve the device, probably by making the struts thinner, which was not 150 microns, and improve mechanical properties without much of strut fractures. That is improving the radial strength of the absorbable platforms would be better. That's how people went on to work. Now the Riva platform and then the Biotronics magnesium platforms are working on it. These are the first generation one, which had a very thick platform. Initially, it started with 228. From where at 150 range, it was launched into market. Then it's further coming down and down. And now this Merrill MIRES is 100. They call it as MIRES 100. That is 100 micron strut thickness. And Abbott is working on the second generation. Again, further newer advances of BVS with less than 99 platform. It didn't come to the market yet. But 26 January, as latest as 26 January, MIRES stent is launched in the country. It's available for the patient used. And one important thing which they made is it combined it with a pre-dilatation balloon and post-dilatation balloon in the same stent and the same cost, so that you'll be almost mandatory to dilate it pre and again do a dilatation post with a quarter size balloon bigger. So still we want a better stent to be working in all these platforms, STEMI, bifurcation, CTOs, multivessel left main routine everywhere. And without having the stent struts, that's where our vision with absorbable platforms. Then when you compare with MIRES 100, absorbable, again, as I said, is 150 microns and MIRES is 100. This is almost like resolute integrity, which has about 80-90 microns. So that's how strut thickness have decreased. So if the less of the strut thickness, probably people think that less of thrombosis could happen. But at the same time, then patient that scaffolding effect should be there because of hybrid geometry, which again has the open and closed cell design combinations. Then probably patient this stent could have maintained the radial strength. And the markers are also improved. They've made 3 markers on each side of the stent so that you could see the stent better. Previously, when you were not seeing the stent better, again, there was edge dissections happened in the previous versions. So closed cell versus open cell, which is bigger, is a combination of this with this MIRES MyVal platform. The studies which shown that at 3 years, it is getting absorbed totally. And that's how the radial strength is also preserved compared to all other metallic stents which are there. Reasonable, again, radial strength even with this. And they're trying to work on this even in the intracranial aneurysm parts, peripheral areas. And that's how Merrill, India, the company is making India proud. And they're trying to work on various below knee stents platforms also Not only with this, but they're working on closure devices and other things with the same material. Hope it works well and it will be useful for Indian subgroup of patients. Coming to the most important aspect, and which many people of you also must be waiting for, is how to select the stent. I have showed you the various types of stent platforms available, touched upon the latest bioabsorbable platform also, and then which stent should be preferred. And these are the broad guidelines. Each of you could become comfortable with any of the stents of your choice. But generally, some advantages, some particular things which are mentioned, which are studied, I would try to mention here. Younger patients, probably age less than 40 years. These are the patients who where the stent starts, if they disappear, it is good. And these are the patients also, maybe less chance of thrombosis could also be there. So newer BVS platforms with thin stent struts could be useful. But if it is not available before, probably we were using longest follow-up studied platforms like Zymes and Resolute before in these younger patients. But ideal BVS could be a solution in these patients. Then elderly, high bleeding risk patient, we have now data coming with Onyx and Zymes, short DAPT studies, and we need to club this with the proper radial axis to decrease the bleeding. So probably in elderly, you should keep the stents in which have a least thrombosis, and then a shorter duration is studied. In sex females, Spirit Woman study was particularly addressing with design stent, but even other stents had about one quarter of the other studies also had some females, but we are somehow more comfortable because large data is generated in females in this. Diabetics, initially Resolute platform got approved by US FDA, and then later on the Zyme Sierra got approved. And the Ability Diabetes Mellitus trial with Indian abluminous stent is again being tested with Zyme's platform. Probably this could be an effective Indian solution for in diabetic patients too. Recurrent MACE events in patients in which it is likely to have probably instant restenosis, TLRs, or again, we tend to bank on that stent like Cypher of Esterera of Zymes. And the patient has CKD, LV dysfunction, try to keep the technique simple and don't put too long stents, and try to limit the size of the stent and try to do a quick job and come out without getting into too much of trouble, too much of contrast. And stent choice, another important thing, I think coronary anatomy factor is very important. When you're dealing with left main or LAD, LCX, RCA, osteal locations, we have to place the stent very precisely. The Zymes platform, where the stent starts with the marker and which also has reasonably good higher radial strength, is what is preferred. The left main crossover requiring a part, again, the proximal should be big and distally should be thin. Then probably Onyx design is preferable because it doesn't distort the anatomy. The Sierra also has a higher size stent. This is not available, unfortunately, in the country, and that's how it is preferred there. Bifurcation of the large side branch, we need to have open cell design stent. Previously, we were banking on Onyx, and now Sierra also has a larger side holes, and then Synergy also has some similar ones. So in bifurcation lesions, when you're dealing with large side branches, you need to have open cell design stent. Tortuous vessels, you need to have the lowest crossing profile. Probably some of we tend to select Onyx platform, which I've shown in that 80-year-old lady with a large tortuous LAD. Small vessels, that is less than 2.25, we have very strong data with Onyx coming up, and expansibility is also good. We tend to use that. Calcific vessels, where you need higher radial strength, probably Zymes platform with a longer follow-up with a good radial strength we prefer. And especially when you are dealing with a patient in which instant restenosis have happened, probably you try with the regulating balloon, depending upon the type of cause for the restenosis you decide. But if the stent expansion, under expansion is a problem, you expand it well with the regulating balloon, you treat it. But if in spite of all that, if it's diffuse atherosclerosis, probably you can use alternate tests. If the restenosis lines, you use this was more relevant in paclitaxel versus limus, but now at least with one drug type of stent restenosis, we tend to select the other. So these are some of the broader guidelines, I would say, but each of you should become comfortable with one or two types of stents which are do it and be compatible with it. Conclusions, coming to it, we have come a long way from the evolution of PCI. It is exciting rides with many twists and turns, but I feel the best is yet to come. If you see this was proposed by Antonio Colombo, a great man again. Rather than making it long metal tubes, if you do proper predilatation, without that, immediately if it leads to occlusive dissection, probably you could use one focal stent or a BVS. If it is optimal result without a major dissection, then probably you can assess the gradient and do a spot stenting or use a drug-coated balloon distally with a diffuse disease. Whereas if gradient is more, where definitely need a stent, probably you can do BVS or a short metallic stent. So probably rather than making the entire arteries through tubes, some of these distal diffuse disease could be tackled by drug-eluting balloons also, but we need to have more data with them. As of now, I think we should not. We should try to avoid putting too long stents. Many of the youngsters, what we see, is especially in primary scenarios, in emergency situations, is different. But otherwise, you prepare the bed with a tight focal lesion, you inflate it, give nitro, and then assess the vessel well distally, and take the appropriate size stent. Normal to normal doesn't mean that every whole extent of the stent you cover with the whole artery you cover with the stent. But basically, wherever you find the minimal disease, you can still do rather than putting a very long stent. I think that's what we need to use our discretion and experience to give optimal results to patients. I think with this, I'll stop and have a Kahoot advanced quiz, and then probably go for taking chat questions. So the quiz is also going on. Probably you can express your chat questions, send questions in the chat. I think many of them answered the Kahoot quiz things also in these chat questions. One question from Ramya, sir, any choice for thrombotic? Sure, that's a good question. And when you find ACS type of STEMI type of lesions I didn't cover, basically, we were worried to use drug protection before. Now I think they're proven beneficial. And there is no problem to use any type of drug stents also there. Previously, mesh coated type of stents like MGuard was being tried. Now it is given up because it was a bare metal stent. So now this thrombo-resistant polymer type of stents which have like Exine's platform, which is supposed to be having albumin selectively attaching there,
Right.
and without antiplatelets clogging there, probably could be preferred. But you need to again try to avoid taking too long stents in that scenario, and try to use a stent length which is optimal and as required to tackle these thrombotic patients. I think now with this, I'll try to go on to the
ಏನಿದೆ ನೋಡು.
Give me 1 minute, please. Now we'll go on to this advanced stent quiz. Not opening. What is the problem? Are you able to see the screen now? Achha, we didn't have the pin now. Meanwhile, you can use this time to pose chat questions. The pin generation is not happening. I think now it will work. This is the uh, pin 0432826. Please log in with this pin 0432826. 0432826. So not many people could log in. Till we wait. What is shown here, they said for the winners, they would give this thyroid collar. A new pin has come. I think with this, this is live. I started practicing it before. That's how the old pin is coming. This is, I think, you have to log in by this pin. Please try once, otherwise we'll give up this. We'll take some chat questions before we break. It's already 7:30. 033 55 528. Some of the important aspects of what we discussed also could be covered. Stressing points. That's how I thought we would have with this. Major advancements in stent type happened with, as I said, thickness, polymer, drug coated coating. All of it has happened. So all of the above is the answer. Probably many of you are not able to participate. You can write in the chat if you want. Which is the main stent design which matters in bifurcation lesion stenting? Bifurcation lesion drug type, metal type, strut thickness, open versus closed design. What matters most? The top diagram here actually shows whichever the open cells which have maximum diameters available. I think open versus closed design is the answer for the bifurcation, which will deal more in this thing. And then if we finish the two questions, this we did it already. Today it is creating little more trouble. The other The most important character of stent for the left main stenting. Which type of character is very important? I said when you're doing a crossover stent, the expansion limits have kept on the top. The chart you should have the differential expansion along with proper studies and what is available with imaging. You take the prefer that stent there for the left main stenting. Then if you go to stent with the maximum number of studies and randomized data as of available today, earlier were Cypher, now I think Science has a maximum number of studies available. Onyx also next follows. And probably Midas is the most latest generation stent on the platform which has come. We need more studies with it. And resurgence of bioabsorbable stents is brought by which stent company? Probably you need to type the answer here. That is Midas 100 of Merrill. Sorry for the many of you are not able to do this right this time, but probably will again further evolve for what is this problems happening. So that's how I think we have finished this. But I'll close down this, stop sharing, and we'll keep everybody on the screen, and then probably have some chat questions if you have anything before we break. Did you go back to this the previous screen?
Sir, it is showing us Kahoot Advanced chat Q&A. Yeah.
Okay. So we'll go on to the chat questions. I think the last slide which I wanted to show is also important. Conceptually, people should think about this also. Decreasing the amount of metal in the stents, how to proceed it further, whether take a help of regulating balloon, and how to optimize the results. Another new concept which is coming up. So that's why I said in this last slide, the best is yet to come. Probably we can limit the amount of metal in each. Those stents are performing well. Nothing replaced to all patients' own vessels. I think with this, we should close on this, and I would be happy to take any chat questions. Thank you. We can make a gallery view so that as many as people can see. Is it possible?
Yes, sir, it is possible. Yeah.
Yeah. I think now I am able to see the chat questions if something has come. Dr. Ravindra Reddy has asked me before that what is the sorry about this confusion about PIN and other things. Many of questions are on that. But I'll take questions one by one. Dr. Ravinder, what is the status of the bioabsorbable stent and evidence, the new generation? That's what I mentioned in the talk. The more thinner studs of the available BVS supposed to be good, and 100 microns thickness of Midas, that's why we call it as 100, is launched in the Merrill. And other companies are also working on it. The BVS next platform, they are working, and Abbott is working with 99 microns, maybe same like 100 microns. Then people are also working with a metallic platforms with magnesium dissolvable, absorbable metal. That is from Biotronics happening. And there's a Riva Medical Systems is happening with the BVS, where their advantage of that is supposed to be radio opaque at the same time. Now the present model is only have a markers at the end for radio opacity. Rest of the stent is not radio opaque. The Riva platform wants to work and make the stents little more radio opaque also with the BVS type of platform. Those are the things which are going on. I think we need to use this stents, newly available BVS with Maris carefully and prepare the bed well and post-dilate it well so that we will have good results and follow-up. Then Dr. Deepak Patade, change in the DAP strategy, new stent technology. So that's what we are thinking, that we should avoid giving long-term DAP therapy, especially in high bleeding risk patients. But in younger patients, it doesn't matter really in India, but probably in elderly patients where you have a HBR risk criteria, what I mentioned, you tend to decrease dual antiplatelet therapy duration, maybe limit it to first 1 month to 6 weeks, and then gradually go on to single drug. And somehow we are not comfortable stopping the more potent of the antiplatelets. We tend to stop the aspirin if it is required and try to continue only clopidogrel in these high-risk patients. Probably in other patients, you're using ticagrelor more commonly now. But in HBR patients, probably you could still use clopidogrel. And Dr. Nilesh, what will be your advice for beginners? Which stents to use? I feel for the beginners, actually, what is best available and what is tested, and if you use it, then probably even if some issues are there, you'll be also protected, because it is, again, you use the best possible available platforms and multinational stents with USFDA approved platforms. If you use, probably in these times of litigations and problems, 50% of headache will go away from you, and again, probably use the best possible FDA approved stents like what we mentioned is Zynes or Resolute Onyx. But mind you, don't keep on using one stent of various types. You become comfortable with one, two types, which are two to three, basically, to have the different sizes available, overlapping. Sometimes exact sizing may not be available in each company. So probably one or two companies, you can have it on the shelf and then probably start becoming comfortable with those. And then you should also become comfortable with the inflation patterns, the nominal atmospheres. Some, because Zyne's platform has a nominal of 10 atmospheres, whereas others will have a nominal of 12 and 14. So those are the things, intricacies. Sometimes you should be careful, and that's how I think. In our group, we tend to work with the multinational companies. We request them to give stents for even orchestra patients at lesser price, and even the youngsters who are doing also should not have this headache of some of these balloons. Indian companies stent strut thickness is quite good, but sometimes we tend to get it getting dislodged from the balloons when you're trying to push and pull, because approximation and then crimping off the stent platforms on the balloon sometimes occasionally could be challenged. So that's how we tend to switch on to the most maximum available data stents in all subgroups of patients. Uh, Dr. Ramya is asking, good evening, sir. Any choice of stent design if the lesion was calcified and bed was prepared with rota or IVL? That's what I said, in calcified type of lesions. And if you have, you need a better trackability on one way. At the same time, radial strength also should be good. So you need to have a strut thickness again being less, and also radial strength also should be good. So that's how we tend to use Resolute Onyx or the Zynes platforms in the such lesions. Then Yashwant Lakshmaya, hi sir, what is the status of abdominal surface coated sirolimus everolimus stent with biodegradable polymer matrix? What is the true importance and data? That's what is abdominal stent, abdominal coating of the drug is only being tested. The other advantage of that platform is now the stents have the drug only on the stent struts and the abdominal. That company is also trying with, they have a drug-eluting balloon also of their own make. So even the balloon on which a stent is crimped, they are having a drug, so that entire surface of the artery, the drug is at least deposited once. So it is not a stent alone, but it is a drug-coated balloon with a, again, drug-coated stent over it. That's how it is. And the uniform distribution of a drug, what they claim is supposed to be maybe better. And that stent ability diabetes mellitus trial, which I mentioned, they're trying to compare with the Zynes platform. Hopefully, we need to wait for the results. And 1,500 patients, large study, multi-center analysis is being under planned. Antonio Colombo and Mary Claude Morris are the PIs for it, and they have also requested many of the Indian operators to be part of it. Dr. CV and Murthy, are thinner struts better, or is there an optimal thickness? Yeah, that's what we discussed upon. Compared to first generation to third generation, the strut thickness have decreased right from 150. Now it is around somewhere, the least one is of 60 microns. And somewhere around 80 could be okay, because if you make it too thin, again, the radial strength could decrease, and sometimes you could land in the stents becoming crimped and shortened. So that's how people are working around, mostly around 60 to 80 microns strut thickness. And if you go down further below, you may not achieve further better results, but on the other hand, you could have a less of radial strength, and then probably stent shortening, things like that could happen. I think these are the pins which are entered. I think this time we couldn't enjoy the Kahoot app very much. The first two basic ones, whatever there, then they would help you with that thyroid collar. Many of them would get anyway. Then Andrea Grunzig is what is the type thrombotic lesion stent choice I've answered. Covered stents, this is a good question, Walim Pasha. Then what is the status of covered stents? Covered stents are basically now used only when you get into perforation, because these covered stents, however thin the cover is, like papyrus coating which has come now, which is a 5 French compatible, still used only in patients of where you get perforations with regular stent, because again, the covered stent, the more cover it is, the more chance of restenosis happening, thrombosis happening. So we'd use it only when it is absolutely required. All other questions are regarding the pin. I'm sorry for it. Is this different pin or from the lead one? regarding what is the current role of drug-eluting balloon. Current role of drug-eluting balloon is basically people are trying the various concepts which I showed in the end also could increase the use of drug-eluting balloon. But as of now, the definite approved indication of drug-eluting balloon is in-stent restenosis, especially when the expansion of the stent is all right, but only atherosclerosis has happened. And if you see that less than 50% of the material gets deposited in the strut within the stent, that's where you're supposed to be getting away with the drug-eluting balloon. That is the indication. Second thing is probably in the smaller vessels where about 2.25 or 1.5 vessels, then probably where you can't afford to put stents, long diffuse nature of disease, again probably drug-eluting balloons could be used. When people had some challenges with paclitaxel, then there are worries of increasing malignancy elsewhere in the body. So that's how paclitaxel is becoming less common. But now Limus-based drug-eluting balloon, Magic Touch balloon, is an Indian company, made the world proud, and again that is being tested and tried in more number of patients. That is the answer for drug-eluting balloon. For osteal lesions, which stent to be used, that's what I mentioned. To place the stent precisely at the ostium, the Zynes platform has an advantage to position it exactly at the ostium without coming onto the main vessel. And again, you have a good radial strength too. That's how we prefer using in osteal lesion that stent. Dedicated bifurcation stents patient presently, tapered stents also, they can come for short duration. Yes, tapered stents, again, the proximally bigger and distally smaller. The tube is same, but the balloon has differential expansion capabilities. Actually, Merrill made one, and other companies are also trying for it. But basically, even the other ones, regular ones, which have more complex nature, proximal expansion can be made bigger. That's how other companies didn't come with that tapered type of stents. But Merrill made one tapered stent, and one or two other companies are also trying. Dedicated bifurcation stents, basically, we need to preserve the access for branch always, and then various types of specialized bifurcation stents are available. I will touch upon these more because sake of time. Already we exceeded, it became 7:30. I didn't deal with it in detail. I would take up all that in a bifurcation session coming up things. I think with this, I think a lot of questions are done, and it's already 7:45. If there are no further questions, I think we will close this session. Is it okay, Vignesh?
So Vignesh sir had some connectivity issues, sir.
Okay.
Yes.
So I think we'll it's 7:45. Thank you again for all of your interest, and thanks for participating. And the next session would be on a multi-vessel PCI approach. I'll tell you the concepts of multi-vessel PCI, how to decide, and show you some interesting case examples too, and also touch upon the utility of FFR and QFR and how to deal with it. And probably we can have that on 27th February. That is the last Saturday of next month. And people would remind you again. Thank you once again for all your patient hearing and active participation.
Yes.
This I close.
Yes, sir. Yes, sir. Thank you, doctor. Thank you for the wonderful session, and thank each and every doctor for participating in this Cardio Next. The next Cardio Next session will be on 27th, which we will remind you. Thank you once again, everyone, for joining the session. Thank you, sir. Thank you.